We're about to start this session, which is on drug resistance and more particularly drug-induced resistance. So, I mean, it's not the only theme that people will talk about, but we try to find common themes among the talks of the session, and so that was the common theme for the three talks. So the first speaker today is Eunjung Kim. She is currently in Korea where it's 11 a.m. So she deserves a big round of applause because she's attending this talk from 11 a.m. to 2:30. Sorry, not 11 a.m. 11 p.m. to 2:30 a.m. in Korea. So that's really a non-standard thing to do. So thank you, Eunjung, for being here. And she's a senior research scientist at the Korea Institute of Science and Technology. Before that, she studied mathematics in Korea and then in North Carolina for university for her PhD. And she then joined Moffitt as a postdoc and research scientist for almost 10 years before being back to Korea. She has been working on various facets of mathematical oncology. And today she will speak about understanding the potential benefits of adaptive therapy for metastatic melanoma. So Eunjung, the floor is yours. You have half an hour.
Okay, thank you. Thank you for introduction, Yannick. So today I will talk about different mathematical models that to aim to understand potential benefits of adaptive therapy for metastatic melanoma. So in melanoma, there was different intermittent therapy applied both in vivo and in the clinic. So this is the result from the that investigated the benefits of intermittent therapy. So as you can see on the curve on the right, survival curve, the intermittent dosing they applied, here they applied all fixed schedule, 4 weeks on, 2 weeks off therapy, improved survivor significantly. You can see the solid line is intermittent therapy and dashed line is continuous therapy. And also the reason for the authors argued that why they see this improvement was that their resistant cell population, which is BRAF mutant but resistant to the BRAF inhibitor, they become dependent on drug to survive. So they need to have some drug around to survive. So when they take off therapy, they see the negative growth effect. So actually the shrink of the tumor. And also, if you look at the tumor volume dynamics of intermittent therapy, left bottom curve, we see the very diverse dynamics. In some case, this is a patient-derived xenograft. So in some case, they see the all regression of tumor at the end of 200 days. In other cases, they see the gradual increase of tumor volume overall when they add more cycles of intermittent therapy. So in the clinical trial, there are a couple of clinical trials. We challenge BRAF inhibitor for the metastatic melanoma patient who stopped treatment because of the side effect or progression or switching to other therapy, for example, chemo or immunotherapy. And then they, 4 to 12 weeks, and then we challenge the patient with the BRAF and MEK inhibitor. So as you can see in both clinical trial, they saw that the patient responds to the same drug. Some show partial response, which is 25% decrease of the overall diameter of tumor. But we see the benefits of this rechallenge varied between patient. You can see on the left and then different tumor diameter curve in the middle. So you see that overall the observation, some have benefit and others don't, and then duration of this benefit response time is quite different. So there is one big phase 2 trial of intermittent therapy for metastatic melanoma. So they use, again, BRAF MEK inhibitor combo. So this is a phase 2 trial. They finished this year, published October of this year. And then they compared intermittent dosing. So all patients had 8 weeks continuous therapy lead-in. And then for intermittent arm, they had 3 week off and 5 week on therapy repeat. And then the other arm had the continuous maximal tolerated dose therapy. And then they had about 200 patients in both arms. That in each arm they have 100 patients. And unfortunately, as you can see on the left, this intermittent therapy, which is indicated by the dashed red curve, didn't improve the pre-progression free survivors. So they saw the different mets appearing or increase of the tumors under intermittent therapy more frequently than continuous dosing. So in terms of overall survivor, they didn't see any difference. And then in terms of side effect, the two arms appear to be same. So one of the reasons why this intermittent therapy didn't show any improvement, although the other study in clinic or in vivo study show benefits, was maybe the 8 weeks lead in the continuous therapy maybe already select for the resistant population, given that melanoma progress, some melanoma patient, the tumors progress very quickly, like 3 to 6 months. And also the fixed dosing of 3 week off and 5 week on maybe wasn't optimal in the clinic. So again, back to prostate additive therapy clinical trial. So we see that all patients had different benefits. So and then duration of on and off are quite diverse, they're different between patients. So to investigate this, to implement actually this individualized adaptive therapy in mouse in vivo model, so we tried preclinical trial, adaptive therapy arm, if you like to say. So we had 3 arms, so continuous of MTD, BRAF inhibitor, and one fixed schedule, 2 week on and 1 week off. And adaptive therapy, which means that we modulate on and off schedules based on the tumor volume changes of individual mouse model. So when we decide this on-off schedule, we use mathematical model to determine schedule on and off. So before this in vivo study, actually my collaborators, Kiran Smoley lab, they investigate the many other factors to determine which xenograft model we have to establish first. So in their lab, in his lab, they have they derived multiple resistant cell line resistant to BRAF inhibitor, and this are 2 representative cell line. And using this cell line, they made resistant cell line and take off therapy from 1 week to 10 weeks, and then compare see if the sensitivity to the drug BRAF inhibitor recovers. So on the left cell line WM164, as you can see here, the curve, dose response curve are moving down to parent curve, black solid line, when they take off therapy from 1 to 10 weeks. However, in the other cell line, we don't see any difference, the change of this recovery of sensitivity to inhibitor. So to differentiate this difference, they investigated further to actually profile the transcriptome of the cell line, and then as you can, and then categorized into 3 states: one sensitive state, which is indicated by red, and then moderate sensitive cell, green, and then most resistant cell, cyan color. So in one cell line W164, we see that the proportion of these states are changing when cells become resistant to therapy, and when they take off therapy, this proportion came back. However, the other cell line, we didn't have one state, critical state, that is most sensitive to BRAF inhibitor, and then we don't see big change of the proportion. So based on this observation and other observation, we decided to use xenograft model using WM164 cell line. So the goal is to maintain drug-sensitive population through adaptive dosing per individual mouse model, and then where the dosing is determined by the mathematical model. So from this study, from the previous observation in the lab, and then actually the other experiment based on the in the graph on bar chart on the left, you see that the state, there are 3 states are quite changing a lot when they changed, used the different schedules. And so we thought that this may be due to the state change plasticity between S and R population. So in our model, have 2 compartments, S and R, where we assume transition from S to R when therapy is on. So transition rate is the rate of alpha. And then the reverse change R to S occurred at the rate of beta when therapy is off. So the bottom equation describes this dynamics of S and R in this melanoma cell line. And next step to apply this model in actually in real life to make decision, we have to estimate the model parameter that tailor mouse model, individual mouse model growth dynamics. So to do that, we as we make prediction in real time, so we collect tumor volume changes of individual mouse model every 2 to 3 days, and then integrate it into model and estimate the model parameter repeatedly, and then make prediction for assuming 2 scenario treatment on to 2 days and off to 2 days, and then decide which way is better. So, and then as you can see on the left, as we collect more data, we see that the uncertainty, the error at the end of therapy decrease. So we repeat this for all 11 mouse models, and then decide predictive these different diverse on and off schedules. So here the gray color indicates on and white color indicates off. So as you can see here, all 11 mouse had different schedules, and then effects are different as well. In some cases, we managed to control tumor growth less than 25% increase, and how in other case we the tumor volume increased up to 9-fold despite of this adaptive scheduling. So we see this variability between mouse model even with the same cell line implemented. And then we predicted cell SNR proportion per individual mouse model. So we sorted this based on the tumor size at the end. So the pie chart on the right end has indicates the correspond to the tumors 9-fold increased tumors, and the first one is very 100. That we managed to control tumor volume very well with the adaptive dosing. So in overall, at the start of therapy, we have more S population, and at the end of therapy, we have more R population. So in some cases, we managed to maintain S population quite well. In other cases, we have mostly dominant R resistant cell dominant population. So in summary, in this preclinical adaptive therapy trial, we had 3 arms, and then at the end, if you see the tumor temporal growth of these 3 arms, and then on the average, the fixed intermittent therapy didn't show any statistically different in terms of controlling tumor volume. However, in adaptive therapy, we see that average tumor volume is about half of the continuous therapy with a half dosing of the continuous therapy. So back to the clinic prostate cancer adaptive therapy result, we see the variability of this on and off schedule and the benefits in both clinic and then in vivo. So our next question was, what are the underlying mechanisms that explain this variability, and then what can we predict? So what are predictive factors to determine these potential benefits of adaptive therapy? So these are our questions. So to do that, we decided to develop 2 different models because first of all, we applied this to melanoma actual patient data, where all patients had a continuous BRAF MEK inhibitor and all progressed. So the data is the patient serial biomarker data, lactate dehydrate, LDH, where doctors in the US are used to monitor melanoma tumor burden change. So because these value markers correlates with, when this marker is increased, it correlates with the progression, and then when they see decrease of LDH value, they see the response. So this is only markers, serial markers that we can obtain frequently in the clinic to measure, to monitor tumor volume. So these are the actual data. So we have 8 different patient data. So we have CT image reading, PD partial reading, and LDH increase. So in all cases, we see that there is tendency of the LDH, so increase of LDH when patient has shown the progressive disease in the image reading. And then to use the model, we decided to develop different models. So because we wanted to make ensemble predictions as in the weather forecasting, because we don't think that there will be one best model to explain the tumor dynamics. And then there are some uncertainties because of the dependency on initial conditions and parameter estimation. And then we don't know fully know the mechanisms, and then some other stochastics. So as a start, we developed 2 different models. So one model is drug-induced phenotype change model that I just showed you. And the other model is lactobacillus comparative model, where we assume that S population inhibit growth of R population when they are close to the carrying capacity more. So for each model, we estimated model parameter for patient, and they minimize the difference between LDH measurement and the model prediction. And then we made predictions of the adaptive therapy. So we in this simulation, we assume the same criteria from prostate cancer adaptive therapy trial, where we assume the therapies stop therapy when LDH drops to 50% from the initial value, and then we take off therapy, and then we resume therapy when LDH recovers to initial level. So as you can see in this example, this cyan color, that the patient underwent continuous therapy. The patient progressed about 6 months later. However, adaptive therapy actually showed that it delayed progression up to almost 5 months with at a dose 54% dose rate compared to continuous therapy. So in this model, we didn't estimate, we estimate all other parameters. We didn't estimate transition rate from R to S beta and the sensitive cell growth rate RS, because these parameters can be estimated when we have data of treatment off. So we varied this parameter and then simulated adaptive therapy for all patients using calibrated model, and then calculated the time gained compared to continuous therapy. So how long we can delay progression. So these 2 parameters seems to be key that determine the benefits. So when RS is small and then transition rate beta is high, we see that up to 20 months delay of progression at a dose rate of 20% compared to continuous therapy. However, when we decrease the transition rate, the dose rate increase, and then the time gain is decreased up to 3 months. And we have even higher, when we higher growth rate of sensitive cells, we had to apply more dose, and then benefits decrease as well. So from this simulation, we learned that these 2 parameters, beta and RS, may be predictive factor for determining benefits, time gains of adaptive therapy from continuous therapy. And then we applied a different threshold. Here we stop treatment when LDH drops to 20% from initial, and then and then take off therapy, and then we challenge it when it recovers to initial. And then again, we just set two parameter, beta and then RS, and estimated time gained in terms of month, how much time gained from continuous therapy using adaptive therapy. So again, using less aggressive threshold, we predicted that time gained is up to 25 months, and with a even smaller dose of the 6% compared to continuous therapy. And then we compared progression-free survival, where we assume that progression happens when LDH reached to 50% increase from the initial value. So as you can see in the three different curves, compared to continuous therapy, both adaptive therapy arms improved survival, and 20% does better than 50%. And then applied same process with different model, this comparative collectible comparative model. We first estimate the gross estimate model parameters using from the 8 different patients, and then simulated adaptive therapy, first using 50% decrease as the stopping threshold, and then 20%. So in this model, assuming this model mechanism, so we predicted that adaptive therapy delay progression of about 4 months, which is less than the predicted delay from previous drug-induced model, which was about 5 months. And then from this model, we calculated the key parameter that seem to determine the benefit time gained. So which were the initial sensitive cell percentage S0/K, and then comparative strength C. So for this patient P1, the initial cell percentage it was estimated quite high. So no matter what value the tumor had in terms of competitive constraints, the benefit of the adaptive therapy was high. So it's up to 6 months increase delay of the tumor progression. But when we had a very small cell percentage of sensitive cell population relative to carrying capacity, the comparative strength coefficient matters when it has higher competitive strength over our population. We have a more longer, more delayed progression. So on overall, assuming this comparative mechanism for tumor growth, the model predicted the time gained is about 6 months, which is quite different from the other models. It was up to 20 months. And then again, we used 20% stopping threshold, and then compared progression-free survival of continuous and then adaptive arms. And then adaptive therapy overall performed better, and 20% does better than 50%. So in conclusion, we observed that the effectiveness and on and off schedule of adaptive therapy varies among patient and then mouse models. And then to understand this variability, we developed 2 different mathematical models that assume competition, so strength, and then plasticity of the SNR phenotype change. And then we predicted overall adaptive therapy improved progression-free survival. And then we determined the key predictive factors, which was initial number of sensitive cell percentage, and then competitive strength coefficient C, and switching rate from R to S, and growth rate of drug-sensitive cell population. And lastly, I would like to thank my collaborator, first of all, my mentor, Sandy Anderson, and then Joel Brown and Zineb, and then experimental collaborators, Smolly Lab, Kiran Smolly, and Ina Smolly. Okay, thank you for your attention.
Okay, thank you, Eunjung. And so there are some questions, and if some people want to ask more, welcome. So the first question is by Vaide Vakil. and concerns the mass in the model. Question is, why didn't you ignore the death rate of R in the model? So there is a death rate which I think is delta S for the sensitive rate, and there's no death rate for the resistant cell.
So we for simplicity, we wanted to reduce number of parameters to be estimate. So that's why we didn't assume any death rate of R. So we could have like a natural treatment naive death rate of R and S. So just purely we wanted to start with a very simple model.
Okay, thank you. So there is a question by René Brady, who says, Eunjung, at least 4 mice were on the same model, suggested treatment schedule, but their tumor growth varied by quite a bit, from 200 to 900%. Do you know what is driving those differences? Do their parameters significantly differ?
Yes, actually, the initial size of tumors of these 4 parameters are quite different, and so the predictive parameters, estimated parameters were different. So that's why we saw, even with the same schedules, we see that big difference between the in terms of final tumor volume.
Thank you. So Carlo Male asks, I'm surprised about the competition coefficient. It seemed like a higher effect of sensitive cells on resistant cells resulted in almost no gain. I thought that was a strong driver of success of adaptive therapy.
So, so in this is if you look at P2, so I don't know, can you see my slide? So P2. So
Yeah.
if we have a higher coefficient C, we have a more time gain. So up to 3 months, the patient expect to have a time gain of about 1 month. So with the higher value, we had 3 months gained. So in terms of parameter estimation, we didn't have this parameter over here, so we didn't see in this model and this parameter estimation, we didn't actually investigate actually the effect of C that much. So the only difference we can see was in P2. That was the reason.
So I would have a question myself.
Yeah.
So you investigated in your model, different reductions like of 50% or 20%, and you could go even to 10% or 2% or to something continuous. And so you have an intuition that maybe for reasons that might not appear in the model, intermittent therapy is better, because I mean there is kind of an intuition that it's more difficult maybe for the tumor to adapt to something that is changing than to some continuous low dose therapy that would be some constant environment, and so that tumor might learn to adapt to. So what's your point of view on this? Repeatedly model seems to suggest that reducing tumor burden by less than 50% does better, but there might be things, reasons to also to suggest intermittent therapy. So if we could do anything, what would be your intuition on the best thing to do?
In terms of applying.
In terms of continuous low dose or intermittent high dose.
So if we were to apply in the clinic, or? Well,
if you assume that there were no restrictions due to the fact that in the clinic you cannot come back to the clinic every day, you can do that. But if we could have all freedom of giving the treatment as we want, do you feel it would be better to do something like more continuous low dose to stabilize at a given size, or something intermittent?
I think actually I would, if I have right, so I tried intermittent first, and then based on the dynamics of intermittent very short term, and then infer the tumor dynamics using different mathematical models, and then determine if the patient had better expect to have a better result with the continuous model and adaptive therapy model, and the intermittent therapy model. So I think that's my question. So I think first, I don't know if that answers your question. So
that's fine. There are other questions. So
Yeah.
the question by Michael Ratz,
Yeah.
it says, in your 80-time series, the
Yeah.
fluctuations were slowing down towards resistance. Is that a general pattern that is regularly observed?
Fluctuation.
So, well, I don't know, maybe you can show you a 80-time series and says, in your 80-time series, the fluctuations, so I guess you mean, it's going up and down, etc.
Yeah.
We're slowing down towards resistance, so I guess when it becomes resistant. Is
Yes.
that a general pattern that is regularly observed?
Yeah, in this model, we see this pattern of this the slowing down, and at the end, it all went to the fully resistant state. So after some repeat cycles, assuming this mechanism of the tumor growth. Yeah.
And then Carl O'Malley had a kind of follow-up comment on, but maybe you already answered, on his previous question about the effect of the competition coefficient, which says that in a P7, P8, and P3, there is no apparent benefit of a C. So is that correct? And what's your interpretation?
Yes, in this slide, there's not many sensitive cells exist at the beginning. So that's why, so it's less than 10%. So that's why it doesn't matter how high the competitive strength is. So we need to have some amount of sensitive cells, and then competitive strengths kick in to reduce the growth, inhibit growth of resistant cell population.
Okay, well, thank you, Eunjung. So thank you for this night talk and for being with us at this late time in Korea.